Hola, buenas tardes. Gracias por venir. And now we are going to switch in English. Good afternoon. I'm pleased to introduce Dr. Ofelia Olivero from Argentina. She got her PhD in cytogenetics from the National University of La Plata in Buenos Aires, Argentina, and she subsequently came to the United States and joined the National Cancer Institute, and she has been working there since 1987. She actually, I met Dr. Olivero first, she's Argentinian, and she's very close friend working in NIH with my boss, my mentor in Argentina. So while I do in my PhD, I came to the United States for a cancer meeting, and in 1997 I met her in a cancer meeting, and since then we still been friends, and she was my mentor. Dr. Olivero is author and co-author of more than 75 scientific articles and chapters of book, and she has a recent book that the name is Interdisciplinary Mentoring in Science, and she has tips and strategies for succeed. And also Dr. Olivero was doing as a staff scientist, senior staff scientist at NCI, did very nice job, and it was one of the first, the team was the first one in find that the nucleoside analog used earliest in AIDS has some activity as a carcinogen transplant and transplacental carcinogen, and she will share some of the results with you today. During all these years, Dr. Olivero has become an NIH Shining Star on mentoring, and she received several awards, some of them the Leading Diversity Award given by the NCI director in appreciation of all the efforts furthering the diversity and equal employment opportunities. And she was recognized with a Game Changer award that for the Office of Equality, Diversity, and Inclusion from NIH. Also, Dr. Olivero was recognized in the U.S. State Department. She got an award also for the Association of Women in Science in 2013, another award from the Young Minority Females Award from the NCI in 2016, and in 2018 recently has from the Society of Advancement of Chicanos, Hispanics, and Native Americans in Science. Well, Dr. Olivero became in 2016 the chief of the Intramural Diversity Workforce Branch of the National Cancer Institute, and we started, as I say, she was my mentor when I came here to the United States. It's a pleasure to have you here.
Thank you. Thank you very much. This is what happens when a friend introduces you. And you tell her, cut it, don't say that much. And then she kept doing it. Thank you very much. I am very, very happy to be here. And my goal today is to share with you resources, opportunities, and how can you navigate the incredible amount of resources the National Cancer Institute and the National Institutes of Health have to offer for everybody, and particularly for minorities. So there are two programs that I brought in form of brochures, and they are there where you sign in, right? They are. And also a one-pager about training grants for you. You can have it now, give it to somebody, keep it with you. It's a lot of information. It's a tsunami of information. So we need to be prepared and to take pieces that we can take home with us. So even when the introduction was fantastic, I would like to tell you a little bit more about me, because sometimes you wonder, where is she from? What is that accent? So my goal today, as I told you, I will just mention very, very short my own scientific path, how I came, what did I do, and then what is NCI doing to increase diversity these days, which ones are the opportunities to train intramurally, that means inside NCI or NIH, and also what are the opportunities extramurally for funding for people in academia and other places. And then answer any questions I can help answering today. Not all of them, perhaps. So, as you know, I've spent 30 years here, so when I was born, microscopes were like that. No, just kidding. My father gave me a microscope when I was 10 years old, and my passion for biology started then, and I always knew I was going to pursue a career in biology. So, like Mariana said, I come from Argentina, and this is the place where I studied. It's a museum, but the career on the field of biology was taught there at that time. And then I came in 1987 to the National Institutes of Health, and you can tell why I felt like at home. They're so similar. It was not until I put the slide together that I said, wow, this is incredible. Okay, so this place is in Bethesda, Maryland, very, very close to Washington, D.C. Washington, Virginia, and Maryland are all interconnected. So this is where I came. And at that time, I came for 1 year only to do a postdoctoral research in the National Cancer Institute. Because my training as a cytogeneticist, I wanted to connect cytogenetics and cancer. Duh, you say now, right? But this was 30 years ago, so that was a good idea. And it went well, and I stayed there for 30 years. So I never came back except just for Christmas. So I had an incredible, nice experience at the NCI doing research, and I landed in a fantastic lab, and I have fun, and I was lucky probably too, working with a drug that anything you try it with, it was positive. So I did a bunch of things that really got the attention of this drug and what was used for. At the same time that I was doing my science, I was mentoring a lot, and I noticed, not at the beginning, but maybe after 2 or 3 years of being in NCI, that it was some discrepancy or imbalance in the way people mentor minorities, and there were some, I won't say favoritism, but some people was getting more about mentoring than others. So I started to compensate for that, and I started mentoring exclusively minorities, and most of them were Hispanics, and empowering them, just being a role model and showing them it's possible and believing in what they were doing. That was enough for them to really make it happen, and that was really rewarding. So because I talk about mentoring all the time, they asked me to give a talk here and a talk there. Actually, the way it started is I'm very shy. At the end of scientific talks, I will just add 1 or 2 slides about mentoring. I just throw them there and see what happens. And I noticed a lot of people really ask questions about it, pay attention. Then those 2 slides got transformed in entire seminars and workshops of 3 days or so. Somebody asked me, why don't you put together a book? And I ended up doing that, and I published this book in 2013 about interdisciplinary mentoring in science, and it's probably a large part of it is just about mentoring per se. Besides doing those things, I love my garden, my orchids. I am a yogi practitioner. I practice 4 times a week. So I strongly believe in doing wellness and doing things that keep you going, right? And I enjoy living in Maryland. This is not Maryland, this is China, with my family, my husband and me and my 3 daughters. So because we are who we are, I know that words like, for me, showing family is important for this audience, and we connect at that level, so I feel comfortable telling you all about this. All right, so the question. When I came here, I landed in the Laboratory of Cellular Carcinogenesis and Tumor Promotion. At that time, 1987, the AIDS epidemic started, And there were it was a lot going on. CDC, some of you in the audience probably remember, President Reagan wouldn't even say there were AIDS, and there were a lot of connotations that had to do with the population that was first impacted by the disease. At that time, the first drug approved for the treatment of AIDS, AZT, azidotimidine or zidovudine, was approved by the Food and Drug Administration. So the pressure of the activism was very high then, and the need of a drug, or just to show that the government was doing something, was so important that the drug didn't go through the regular preclinical studies and phase 1 and phase 2 and all of the things they go through now to be approved. It was approved in what is called a fast track, and it was in the market immediately. So, as you imagine, there were many instances that were not explored. One of those was when the mother was taking AZT to prevent vertical transmission, when the mother was HIV positive, didn't want the fetus to get the disease. So the mothers took AZT for their own disease and to prevent vertical transmission. But no one knew what was happening to a fetus that was exposed, embedded in a consistent, steady level of AZT for some of them for 9 months, some of them. All right, so that was the question. I was very lucky to be in NCI, in a place in which you don't have to ask permission to work on something, if it is in the frame of research, of course. And the question came clear. Somebody brought to our attention, and we say, okay, let's explore. So I was given a vial of AZT and was told, try it. And then I started doing that, exactly, trying in vivo, trying in vitro, exploring the cytogenetics and also the genotoxicity of the drug. That was my expertise at that time. So what happens was that we engaged in a collaboration with a lab they were experts in transplacental carcinogenesis. Some of you also might remember DES and the story about mothers taking DES to prevent losing the embryos, and then that being a carcinogen in the F1, in the first generation. So ACT was very similar. What happens is that what we did is we treated females, this is pregnancy according to me, so we treated females, CD1 mice, and we gave them 2 doses of ACT while they were pregnant in the last third of their gestation. The idea was that organogenesis had taken place already, so it's similar to treatment in the 3rd trimester of a human pregnancy to prevent teratogenesis and other issues. And most of the protocols in the clinic call for this, to treat mothers in the 3rd trimester. But that is almost theoretical because women are already HIV positive and taking ACT when they get pregnant, and they cannot interrupt treatment because that will be counterproductive and you will generate resistance, right? So some of the women the babies are exposed to ACT during the whole pregnancy. So what we did then, we treated only for this period, and then we allowed the offspring to be born without further exposure. So 1 year later, gotta be patience in science, right? 1 year later, we explored the untreated and the treated groups, and we realized that there was an issue here, and that it was carcinogenesis, and the tumor incidence was critically, dramatically increasing in those animals that were exposed in utero only for a short period of time. And that was in the reproductive organs of the female, in the lungs of the females, and in the lungs of the males, and in the liver of the males. Also breast, you name it. It was all the organs, brain, breast, kidney. The only place in which we have not seen carcinogenesis and we saw a decrease was in the hematological tumors. Those were down, and we have a couple of explanations for that. So this was already a very, very important contribution that we did. Not everybody was very happy with it because somebody has to start recognizing they were giving pregnant women a potential carcinogenic drug, and no one was ready to make that assumption. So what we did then was what any scientist will do is, can we predict if this is going to be bad in humans? Can we have a tool in our arsenal to be able to detect this before it happens? And in order to do that, we did the same experiment, but this time with ice, and we get the animals when they were born, not 1 year later, when they were born, and we explored some of the organs. And at that time, I was able to detect ACT that have incorporated into the DNA. ACT is a nucleoside analog. It's like thymidine, very similar to thymidine. So it will get incorporated into the DNA, not at a very strong rate, but it will get incorporated. And when it does, the DNA stops replication. It's a nick. So that is genotoxic, of course. So what we have here, we measure the genotoxicity in molecules of ACT per million of nucleotides. And we explore tissues and organs, brain, lungs, liver, kidneys, and skin. And in two different compartments, the nuclear DNA and the mitochondrial DNA. And we observe variability. Sometimes mitochondrial DNA wasn't targeted while the nuclear DNA was, and vice versa. The highest incorporation took place in the mitochondrial DNA in the skin at a level of 100 molecules of ACT per million of nucleotides. So the obvious thing, now we have a tool. Now we could predict that if something got into the DNA, could be what eventually will produce cancer later on. So what happens in humans? Do we know? Well, we know that with no intervention, only 25% of the mothers exposed to HIV, to ACT, will transfer HIV to their children. And we know with ACT intervention, that number goes to 4%. And if we add C-section, we prevent the transmission to 2%. So the clinic in NCI, the pediatric HIV clinic, closed. There were almost no patients because everybody was under the drug, right? So we cannot discuss how positive was to include or to introduce ACT into these programs and to prevent HIV transmission. However, it's good to know also what type of side effects we are introducing and if this has potential for cancer. So what we did then was we went to humans and we took blood from mother-infant pairs and we analyzed the incorporation of ACT into their DNA, into the placental DNA and into the peripheral DNA of the circulating blood of the mothers. So the time that we used was from 7 months to 3 weeks of pregnancy, and we observed variability. This is humans. Humans, somebody said, it's a lousy model. It's not mice, right? So you have everywhere, everything. And sometimes probably non-adherence to the drug, and sometimes we have a lot of incorporation into the babies and a little into the mother. So clearly there is no correlation with time, there is no correlation between mother and baby, but the incorporation sometimes is 4 times higher than the incorporation that took place in mouse that then developed cancer, right? So that was, again, a message that no one was ready to receive. And that was a message that we could only tell, this happens in the babies. We don't know 20 years from now these individuals are going to exhibit cancer in an increased manner or not. But at least the studies underscore the importance of following these individuals and knowing what is going on in their DNA and knowing what could the potential for them to develop cancer. And all that opened an incredible, as I told you, era of nucleoside analog epidemiology. And so we know it produces centrosomal amplification, it produces micronuclei, chromosomes that are lost, comet tails, these are chromosomes. This is from 1987, that's why no digital photograph there. We have to take a picture in a microscope with film, and then steady, no moving, move the filter, take another picture on top, and some of the time you get this, and you can see. And these are micronuclei and a bunch of things, centrosomal amplification, and things that we were exploring and finding in this drug. So again, I really enjoy what I did. I know that I wasn't intending to have an impact, a direct impact necessarily in human health. I was just doing my basic science thing. But one day our research was in the newspapers, and CNN called. And as a government employee, you cannot talk to individuals like that. You have to have a press. And then when these things were public, they had to call for a panel of experts, and Glaxo Wellcome, manufacturer of the drug at that time, came, and in the newspaper they say, Olivero versus Glaxo Wellcome. And I am small, but I felt really small then. But that gave me the opportunity to stay as a permanent employee, because the panel decided we needed more evidence of what it was going on. And they gave me a permanent position in NCI. So that's the story. And I stayed there for 30 years in that lab, and I did other things there. And again, cultivating that mentoring culture and being very, very pleased with the product. And once the lab, 2 or 3 years ago, closed, they offered me to transfer to other areas of the organization, the areas of training and education, and be able to do the mentoring and to help with the diversity initiatives and to move forward agendas that until then weren't there. So it was easy for me to accept a job that was a passion and I was doing anyway, and now it was going to be my everyday job. It was not easy to leave the lab though. When you hang your coat, you notice something is missing. But after so long, I'm used now. But just tell you, if you are thinking about transitioning at some point in your career, you are going to have to deal with your identity. So what I'm going to talk to you today is about 2 phases of the National Cancer Institute, the intramural funding and the extramural funding. So for you to have an idea of what is going on and how we divide our budget, in general, the huge NIH, many institutes, 27 to be precise, have money. And the money is divided this way. Most of it, 71% of the money goes outside for research grants. And that is what is called the extramural money, because it's outside the house, right? And in contrast, we have 10% of it for the intramural research. And that's the research like I was conducting, and we don't have to apply for grants because it will be circular to apply for money that we have. And I know that is a privileged situation, and I know that not everybody can enjoy that, but that's why we are held with a high standard, and you shouldn't relax, and being productive is like a must, because you are using taxpayers' money without a mechanism of award. So the intramural research program then takes place here in Bethesda, and in other institutes like in Frederick, Maryland, in Montana, in North Carolina, and in Baltimore. There are many campuses. This is the largest campuses. For you to have an idea, we have 1,200 principal investigators and more than 4,000 postdoctoral fellows. We have one here, at least one, in basic, translational, and clinical research. And that's the beauty, that you can start with your basic science and then collaborate with the clinical scientists in the medical facility, and then do translational research. We also now have an institute that is specifically dedicated to translational research, a whole institute. So they claim that the intramural research program is the largest biomedical research institution in the world. Well, it's large. Okay, so these are the institutes, and today I'm going to focus on the National Cancer Institute, but some things apply to all of them. Intramural and extramural research takes place in all of them, except for NIGMS, that doesn't have an intramural program, and it has all the money of NIGMS is for the outside world, for the academia. So yeah, here it is. NIGMS, you probably are grantees or have been receiving money from them. So all of these institutes have such an incredible diversity in what they explore. Some of them work with diseases like cancer or diabetes or a stroke. Some of them just focus on organs like the Eye Institute or deafness or so. So there is a nursing institute. There are many alternative medicine or complementary medicine institute. You name it. Somebody's doing something that you are interested in. So mental health, children, etc. So what do we do in the National Cancer Institute? Well, we do a bunch of things, but now what do we do in the area of training and education? So we in the Center for Cancer Training would like to help move the careers and the training of different individuals in these three types of divisions: the Division of Cancer Epidemiology and Genetics, the Center for Cancer Research, where all of the basic research takes place, and the clinical research as well, and also some of the prevention. This is an incredible program that I can talk about if you want, on cancer prevention. They invite you, they fund you for 4 years inside NIH. Remember, I'm talking intramurally now. And they also pay for the first year for an MPH, typically done in Hopkins. So because it has been seen that we studied a lot the disease, but we could have less disease if we put our efforts and our dollars in prevention. All right, so as I mentioned, we have extramural funds. I will cover that later. So why training in NCI? I am product of it. I can tell you it's a great place for postdocs, and well, somebody else believes that because it was named the 25 best places to work for postdocs. The facilities are really state of the art, no question. We care a lot about career development, and we provide intense programs that can help you with your career development, with your personal growth, etc. It's not just science. The science we know is taken care of. But all of the other aspects of your growth, we provide with classes, courses, workshops, training on it. So we always have, since it's not an academic place, we don't have classes or so, we try to cover that part by inviting recognized scientists in the field and to give talks. There is a lot of mentoring, and it's very easy to collaborate, and of course it has competitive stipends for the area. The area of Washington is very expensive, and medical insurance for trainees, of course. So we have training opportunities at every stage, right? High school students, college students, post-baccalaureate students. That means when you finish your undergrad and you take 1 year gap or 2 years, you can go to NIH and have a career there. They will pay you, you will produce, you will be in abstracts, you will be trained, you will have a nice letter of recommendation for your application to whatever is next. We have a very good program for veterinary schools, of course medical and dental, and the postdoctoral training for PhDs or veterinarians and MDs, and also clinical fellowship program. I know some of you are in medical school, so I put a slide for you to go look in medical programs and how incredible they are. Okay, so what do I do in my branch? And I call it my branch because they just created it. It didn't exist before. And they just asked me to play nicely, and I do that. So if you are looking for an internship at NIH, if you want to come for the summer, or if you want to come as a postbac or as a postdoc, how do you start with doing that? It's not easy. You need to start big, looking at the opportunities at the whole NIH. And for to do that, you need to go to this place. You Google it. Even the people in this office tell you, don't just Google us. Don't look for a search function in NIH. Google OITE, Office of Intramural Training and Education. It has resources for prospective trainees, for current trainees, also for trainees outside NIH, you here. And also for also lists of investigators and staff that are looking for positions. So this is like one place, one-stop shop, right? Everything is there. And here it shows you how to apply for positions. Once you enter your application, you are visible for the whole NIH. Then there are other things you can do if you are thinking about the National Cancer Institute, for instance. And I will show you. But this is the very first place where you have to stop. Google OITE. Okay, so because you are medical students also, this is the clinic. They claim it's the largest building, brick building in the free world. That's what they say. That means there is one larger in Russia, right? Something like that. I guess that's the punchline. Okay, so it's a huge hospital, and there is only patients here are those that are part of clinical trials. There is no maternity, for instance. There are only rare diseases or experimental drugs that are being used, etc. So collaboration with a facility like that is obvious. And what happens when you want to do something clinically related? You go to this page when you see the training about medical, and you have programs and services for students, all of these, for recent graduates, right? For recent residents or fellows, for mid-career professionals. Other opportunities will be taking classes for continuing medical education and training in general. So everything is there. And sometimes you can even come for a short period. You can take something special. You want to learn a technique. You want to know some clinical trial in particular. You want to be part of some effort. Well, there is a way for everything. So I very, very strongly recommend to go to this place. You can also Google Robert Lembo and NIH, and this page will show up. I am just showing you snippets of the page, but you can go on and on and on and find out what is good for you, and also the questions, and contact people directly, how to apply for programs, contact names, etc., etc. So be sure that this is the place where you are going to stop. You can Google him at NIH, and they are going to show up. This is going to show up. It's a very, very nice person that will help you. So our branch again is trying to attract, recruit, and foster a community of scientists from diverse backgrounds at NCI. And in order to do that, we have programs that go and bring individuals into the NCI and help them grow there, and at least get to know what are their possibilities. We do this at different levels: high school, undergrads, postbacs, and also postdocs. That will be one of our aspects. The second aspect is to grow our own, right? To support our own trainees and new recruits through onboarding and mentoring. So we know we need to provide with a place in which people would thrive. And the third aspect, and some aspect that is probably hard, is to develop and implement activities and programs to create a lasting culture of inclusion. So we need to educate the mentors, we need to mentor the mentors, we need to train in the trainers, and be sure that we are providing with a culture and an environment that really embraces diversity. It's not tolerate diversity, it's not accept, it's embrace diversity. We know what that means. So that is challenging. It's not an easy way to provide it, and we are trying to do some, we are seeing some progress, but we need to do more and more and more. We have a huge office of diversity, the science of diversity at the NIH level, and Dr. Hannah Valentine came from Stanford 3 years ago, because they figured if she could change the diversity in Stanford, she could do it at NIH, right? And that was she was transplanted, and she sees the challenges, but she speaks in a way that scientists understand. So that's very good. She's a cardiologist, and she has a lab in the National Institute of Heart, Lung and Blood. So these are my three main goals, and I'm going to mention some of the things we do there. 2 programs for diversity for summer students and for postdocs. Both of them are there on the table. One is called Introduction to Cancer Research Careers, called better known from ICRC, the acronym. And this program, what it does is invites these individuals. It's very competitive. You apply until November, and they invite 20 individuals in February, and they set up interviews with principal investigators. So that guarantees that the investigators say, well, they asked me to hire diversity, but no one applies. I haven't seen anybody. Well, now you do. So here they are, very competitive. They have experience. They know what they are talking about, and we provide interviews. And then in February we match them, and they come and spend the summer. It could vary how long it is in NCI. This is an NCI program. So once you apply for the larger NIH program that I told you, then you go to the NCI and apply for this program, and then they invite you. Another program, and the brochure is here too, you do the same. You apply for the NIH, and then you look for this particular program. It's called CRI, Cancer Research Interns, and it's a summer internship program, and it was created with the idea that you don't have to have expertise. Now it's so difficult to get people without experience. But the idea was that it's like we will pay, and these individuals pay. The program pays the PI $1,000 for supplies and services. So it's an added benefit, right? And if you don't have experience, that's okay. And the person who runs this program, by Black, will do everything possible to find a lab for you. And again, this is the amount of people that applies is larger than the amount of people we can support. However, the program is very rich, and people come for a second year, not through this program, but when you establish a relationship with your mentor, they will fund you next year, right? And we also have postdocs coming through this program. So these are 2 ways in that you have your first step there in the organization. Another program is the NCI Graduate Student Recruiting Program, GSRP. And this is intended for individuals that are almost there with their dissertation, ready to get their PhDs. And they are thinking, what is going to be next for me? I would like to have a postdoctoral experience. Why not in NIH? Why not in NCI? So what we do is we open, it's going to be open very soon through December. This application, again, is competitive. More or less 100 people apply, and 25 are invited to the NCI in May. And then at that point, 2 days, you visit Bethesda and Frederick because there are a lot of principal investigators in Frederick. And also, prior to your visit, you establish connections with your principal investigators and establish the opportunity of having interviews with them. So you can interview even 7 people in these 2 days, and they know you know them, you know if there is a match or not, you know their research a priori because they publish it in the web page, so you know who you want to interview, and they are also ready to have you. So after that, it's a program that is enriched for diversity. It's not 100% because the government cannot offer things that are not offered in the same level to everybody. So we do focus advertising in order to impact a subset of people we want them to apply, and it's enriched on that. So they come, as I told you, there is also 1 or 2 hours of poster presentation in both campuses, so the PIs can come, chat with you, more relaxed, and see what you do, ask you questions, etc. So this is the web page of the program. Again, it's going to be open through December. You can also Google National Cancer Institute Graduate Student Recruiting Program, or GSRP, and see what the conditions are. We offer surveys, administer surveys to the participants. This is the 3rd year, and they are all very, very happy with how easy and accessible the application process is. So it's simple. You need to upload letters and your statement, but it's very simple. So I recommend it, and this is where people come from. They come from different places. Some of them are local, so we don't have to pay them that trip, and then we can cover another student. So they come from all over Puerto Rico, of course. This is the poster presentations in Frederick and in Bethesda, and it's a very nice atmosphere, and we also present them with a training opportunity, so they know they cannot make it this year, what other roads they can explore to come to NIH. All right, and the second topic that we do is how do we groom our own? How do we empower our own individuals that made it already? They are in NIH or in NCI particularly, and they want to have a good experience and be successful. So for that, 3 years ago, we created the Diversity Career Development Program. We love our acronyms, right? The DCDP. This is our 3rd year on the DCDP. This is our logo. This is one of our classes. This program seeks to empower 12. We started with 10, but I was able to pursue, my boss to give us 2 more vacancies. So we have 12 postdocs, and these are individuals for underrepresented minorities, and they spend 10 months in this program. And the program is very comprehensive. So we have coaching workshops. They have a coach. She is a biomedical researcher that decided to become a coach, so she knows how to connect with scientists. Coaching workshops, we have video conferences, career development workshops, invited speakers. We have mentors. They are expected to have 1 mentor and meet with the mentor once a month, and also now peer mentors, because now we are building our cohort, so the past cohorts are the peer mentors of this individual. We are creating a community. So we also have built a community-oriented activity that they are supposed to design and execute. And this is very important because these programs tend to make us think about ourselves only, and we need to give back and to recognize that there is a community there. Some of the things that we do with this program is identifying and celebrating the unique talents that everybody brings to the table, defining priorities in develop independent research careers and their lives, and mainly because when you are in an institution that is so heavily research oriented like NIH, if you deviate from the track of basic researcher or principal investigator, you are probably not as supported, and we try to make them believe that the career they are following is what they want, their passion, and they're going to be successful no matter which career it is. And of course, confronting their inner dialogues, the limiting beliefs, the voice that sometimes tells us we cannot do that, vision, goals, and learning to have difficult conversations, because that happens. And it's very interesting to see how do they come, the fears, the thoughts, the doubts, and now how do they live, so convinced that they will take the next step, they will be successful, and convinced that this is what they have chosen. So it's very rewarding, and it's a way of, again, building a community and trying to show that we can change and that we can be successful. So, and that's in a nutshell what we try to do in the National Cancer Institute, intramurally, to diversify the workforce. And now I would like to also offer you some hints on what you are probably more interested in, which is the extramural funding of NCI, and how to apply for funds and how to look into those incredible mazes that are the websites. I have 30 years of intramural research and intramural work. So this is not at all my expertise. Amaryllis probably knows more than I do. She's there. She could be your referent. This is not what I do, but I know it's what you want to know. So how come I come here and not talk about it? And I brought also the one pager that is on the table with just a guidance of what are the tracks that you can be applying. Okay. So again, we mentioned that 71% of the budget of the NIH, that is growing every year, is for grants. Okay, and that there are grants at different stages of your careers, like you see here, from high school all the way to postdoctoral training. And also, there are grants after postdoctoral training to transition to PI, or to have your independent research, because it's clear that transitions are the most difficult parts of the whole career, right? So, and there are, these ones are called the F awards in general, right? And these ones, the K awards for career. So, again, predoctoral, postdoctoral, and early stages PI, right? And again, the transitions are probably the most important places where you need support, where going to the next step could be more difficult, leaving what we are leaving behind, where we were comfortable for years or so, and starting a new facet of phase of your career could be complicated. So that's why they are these type of slash grants that will help you transitioning and support your transition to the next step here and here, from predoctoral to postdoctoral and from postdoctoral to early stage. And these are institutional awards also. And these are open to applicants with US visas. And this only. The rest are for US citizens. And most of them require that you are in a lab that is funded with a R01 grant. I know sometimes that is a limitation. When I learned about that, I said, wow, this is really focusing on a subset of people, right? But what they told me is true. The idea is that you will be successful, and you would if you are in a lab that is good enough to have funding. It has been validated by funding. So that's the reality. So, and these are grants everybody can apply. These are not necessarily for minorities, but we do have grants that are specifically guided to help support careers of underrepresented minorities inside NCI. So this is just a page for you to see that the pages are really comprehensive. They really want to help you. But if after you read and look at your questions and so you still don't know, there is always a person, and the name of that person is in that one pager. So, and that person, their job is to answer the phone and help you, guide you, tell you if you qualify, if you don't, what do you need to do now to qualify next year or so. So use those individuals because contact information is important at that stage. So there are a variety of F and K programs, and the best program for you, you need to know. It will depend on your research field, right? That is dividing people in different institutes, depending on the disease or depending on, like we talked today, on the angle you can provide to that disease to be sure you qualify for it. And also depends on the need of additional mentoring or training and how ready you are for your independence. And those are questions that if you cannot answer today, you might talk to these individuals, and they know, they have been doing this forever, and these are the training grants that you might need to apply to have support. So that's what I say, contact the program officer early to determine the right training award for you and to confirm eligibility. If you are in doubt, call them. And that's the umbrella of programs, of training programs. But what happens if you qualify for diversity training program? And there's a whole group of programs that are for minorities. And you need to be sure that you fill the applicability criteria of minority that NIH holds. And these are members of groups that have been shown to be underrepresented in biomedical research, like blacks or African Americans, Hispanics or Latinos, American Indians or Alaskan Natives, Native Hawaiians, and other Pacific Islanders, and individuals with disabilities. So far, that's what the NIH considers. So again, these individuals are always eligible for the training grants I just mentioned before. But this, particularly National Cancer Institute, has this CRCHD diversity training, and this stands for the Center to Reduce Cancer Health Disparities, and it's a diversity training branch, and those are the efforts, right? So this whole program is really specifically focused on minorities and provides support at different stages of their careers, even high school, right? So they realize that interventions early in your career could determine what are you going to choose, how are you going to see scientific careers in a different horizon now. And of course, predoctoral, postdoctoral, and also, and again, in the transitions with investigators. So these are the programs. These are all of the programs you can apply to, and I can definitely not go through all of them, but at least I can show you where can you look into and how can you find out who can help you, what is the way how can you apply, and of course Amaryl is there that can help you with, and I will invite you to give a word or two about your experience with this, because it has been successful. She says she has been supported her whole career, right?
Right. So basically I've had all of those that you've listed there from undergrad.
This is you, Amaryl.
Yeah. Except high school. I didn't get high school. Other than that, undergraduate, predoctoral, postdoctoral, investigator, and I don't even see it here in your investigator column, but the CRCHD has an R21 grant for minority investigators too, which is a scientific grant, of course, for your research, but it takes into account the potential of the person for training.
So one of the questions, and this conversation happened 5 minutes before we entered here, and I said to her, how did you find out? Tell me, I like to know.
Yeah, so basically, I've always been looking into those websites and searching and trying to see where I fit, and I like the table where they have, depending on your career, you can click and find out the depending on your stage, what would suit you at this point?
Because
Sometimes
these
you're
things,
too late in your career for certain awards, but just in time for others. So.
and once you are part of a system at any stage, you know what is coming, right? And these things, let me tell you, my 30 years of experience, do not rain on you. You have to be very proactive. Of course, you might have a mentor or an advisor that can guide you to the right direction, definitely. But that is part of being proactive, having a mentor, asking the question, having the initiative and the curiosity of knowing if somebody can provide you with support, okay? So thank you, Amarilis, for your contribution and for showing that this trajectory can be supported and that you can have a successful research. So the resources then, of what I mentioned today, where I work, I am embedded, my branch is part of this Center for Cancer Training, okay? And I invite you to see it. You just, again, Google Center for Cancer Training, right? And again, Google or ITE for any summer opportunity or postbac opportunity or postdoctoral opportunity, NIH-wide. And also, well, you can look at me, I am in somewhere there, or you just put NCI Ofelia Olivero and you will find it. And the training branch where everybody can apply, but also the diversity training branch, two different sites with two different tracks and opportunities, right? Susan Perkins is part of the diversity training, of the cancer training branch here. And she is the one who provided me with that one-pager. And clinical opportunities, I mentioned Dr. Robert Lembo, so just Google him and NIH and you will find. So for CRCHD, this is the place, Center to Reduce Cancer Health Disparities. Again, always one phone call away. Feel the calling will help you navigate the page and save you time when they immediately tell you, yes, you are eligible, yes, you are not. You need to look here. Okay. Any questions? Thank you so much for your attention. Thank you. I hope I can answer questions if you have any. Yes?
Actually, a question about your scientific part of the presentation.
Sure.
Which is now that it's been 20 plus years, has anybody followed up the babies that were exposed to ACT probe, especially at the beginnings?
Yes.
Doses were higher and what has happened? Has it?
Yeah, and we are, of course, very interested on the outcome, right? Two things happened because of our research. One was that the insert of the ACT was changed and to reflect that it was a carcinogen, a transplacental carcinogen in animals. And the other one was that individuals exposed in utero were going to be monitored and followed for life. And so far, there is an increase in tumorigenesis experienced by individuals that have been exposed in utero. I didn't mention that besides being exposed in utero, kids are also given a bolus dose of ACT at birth to prevent even more. And now, when I studied, it was monotherapy. ACT was the therapy that was recommended, but even in the middle of my studies, it was discouraged to take just one drug because it develops resistance. So there are cocktails nowadays. So that type of combinations, of course, they are going to be reflected later in life. The question is, nothing happens so far. Epidemiologically speaking, we have individuals that have been exposed in utero. They are in the 20s maybe, and they don't show an increase in the United States, I should say, because other people looking elsewhere, like in France, are finding evidence of some tumorigenesis in the brain of kids that have been exposed to combinations. Thanks for the question.
A question also about your research. I found it extremely interesting, and there were a couple of things that stood out for me. It was the difference guess, in the stats for children who were born via C-section versus those who were born naturally. I wondered what happened.
Oh, that is because you prevent the blood combination, exchange, cross-contamination with blood. Yes, yeah.
And then I also wondered if the studies include after birth and any studies that looked at differences between babies that were possibly nursed, naturally nursed,
Oh,
versus bottle fed.
yeah.
Given that I'm assuming the mother received
Yes,
treatments.
yes, a very, very good point. Breastfeeding was recommended to be stopped, to be canceled when you were HIV positive because of the, of course, the transmission via. However, there are areas, that's very nice in suburban Maryland, right? But let's think about the world because, 1% of people are infected here. What happens in Africa where the only way you can sustain a baby alive is breastfeeding? So the study that I showed didn't follow up on that, and I don't know if numbers show up. The cohorts are very small, but certainly the recommendation wasn't followed in most of the world because it was not realistic. It's these things that come out of 4 guys discussing, I don't need to elaborate on that. Right, the disconnect between their propositions and the reality. Yeah, thank you. Yes. Okay, in the front. Go. Yeah, go ahead.
You mentioned the patients in France and Europe that they have found tumors in them. Do they happen to know why? Is it maybe dose dependent, or do they happen to know why?
I think I learned a lot doing these experiments that was not science. I learned how data could be not manipulated by forgotten or looked favorable or not, depending on who you are. So at that time, that was the only drug possibly that you can administer to a person. And it was a very strong and intentional belief that if we stop providing this drug, the epidemic will grow. And it was a very hard time, epidemiologically speaking. So there were individuals that tried to don't look deeply into the data and be a little bit on denial of the data, but other individuals were, like in France, that didn't have those connections with the Food and Drug Administration or Glaxo, were more independent in their analysis and in their outlook. And they were finding things that were not found here. I put it lightly. I have one in the back there.
Actually, you should go first because I have 2 questions.
We have Maria here too. Okay, go ahead.
So this is on the second part of your question. The third part of your presentation. This has to do with inclusion and diversity. The school is interested in applying for a P32 program. And the question is, in the sense of inclusion and diversity, why can students and postdocs and residents that are not citizens of the United States not apply, get excluded by the inclusion principle?
Yeah, I know. And I wish I could.
What in your office do? Because you're in the right office.
No, I am intramural. I can persuade the extramural people. I work for the intramural, and that's what I say. I'm not an expert on extramural, and I ask questions like that. Because if we really want to increase diversity, the very first thing we need to do is open those for diversity. We are in a very difficult situation, administratively speaking, to move those agendas. That doesn't mean we are not going to pursue them. There is only one grant for international, and I was with the asterisk there. Yeah, I know, and I am with you. I am with you. Yeah.
A related vein for, we have a number of students, is really your program that career development program, and you have it structured in a series of 10 months, and there are elements. Are there any one or sets of elements that you feel have yielded greater successes? Do you have any of the outcomes? Because part of it is, our students are matriculated, obviously, those that are here, in terms of the career. What are the things that may benefit them if we're thinking about any of those components? You mentioned everything from mentor to peer mentors to career development to the coaching,
Yeah.
all of it.
Yeah.
And we talked earlier about grit, which I saw that Umberto came. And so he's the person that did his, he's focusing on.
Stereotype. Okay. Yeah. Stereotype threat. Okay.
So you could talk to him.
All right, thank you. So the question is about this career development program. By the way, all of them are in US visas. They are all foreign. Postdocs in NCI could be from anywhere. And since this is a diversity program, some of them are in visas. There are two components that I think are critical. If you are going to choose and say, I'm going to do only two, which ones are those? The coaching and the cohort effect. We have each other. I'm not alone with my fears. Oh, I thought I had imposter syndrome. No, me too. You too? Yes, and now we are connecting because we are suffering from the same thing. And we have each other. We pick up the phone and we know somebody's going to listen. We didn't know if that would happen before, right? So the cohort, that's why they come together, they transit together, they live together. And the coaching is important because it's not individual. I cannot pay for that. The coach comes 3 times a year in the 10th month and for 4 hours doing a topic, whatever it is. Then she virtually connects, and it's incredible because now with this new technology, she's on that screen and we are all, the 12 of us, the 13 with me, sitting there, and we forget she's not there physically. We cry, we do whatever as if. So the coaching is critical. Also, after that, the individual part takes place, not virtually, by email, because they have to do homework, which is reflection, writing their comments, whatever is asked for them to do. Finding their superpowers and owning them. And that's what the coach does. And she is really strong, very, very strong component. And then the cohort part, having them all the time together, doing social together. I cook for them one day in my house, barbecue for them. And we do the activity, the community activity together that gels, that provides opportunities for leadership. Having each other is important. We know we are family. We believe in those things, right? Yeah. In the back, 2 questions.
So thanks for your talk, actually. So my first question is for visa holder people that want to apply to any of these programs, which are incredible. Can the NIH perhaps support is not the right question, but maybe help transition to another kind of visa that will pursue eventually a green card?
The only time that you can transition is when you are a postdoc, because to be a postdoc, you can come, like I came from Argentina, still people are coming with those visas. And then, I don't know these days, but then they might help you transition into an H visa, which has issues with your spouse, because cannot work, etc. So we came with a J1 visa,
Okay.
and then you have the home year, 2-year exclusion, 2 years, but then you get a waiver for that. And NIH can help you with that. And then the green card is your situation.
And the second one, I was actually confused. So let's say that there is a faculty or a principal investigator that I want to work with. Do I like contact that person first before applying to any of these programs for postdoctoral training? Or do I have to apply first and then I pursue contact
It really doesn't matter. It will be look very favorable if you contact the PI, because your interest will be revealed, right? But you might know, if you apply, you might have access to the principal investigators that have a vacancy. They are looking for a postdoc, and what do they do? In NCI, if you go to the OITE page, the green page, there is listed whoever is there and other institutes too, right? Because you need to be sure you find a person that has an opportunity open, right? Yeah.
Thanks.
You're welcome. Are we done? Thank you.